Great, thank you. Good afternoon, everyone. I'm Jennifer Muthig, your Executive Director of the New York State Association for Rural Health. Thank you for joining us for today's presentation, View from the Hill, Updates on Rural Health Policy, led by the great Dr. Carrie Cochran-McLean. I was fortunate enough to catch this session early in November at the Northeast Rural Health Association, and Dr. Cochran-McLean does a fantastic job at breaking down HR 1. Now, while Congress is in a hurry up and wait game, we're grateful that Carrie was here today to share with us her knowledge. So before we get started, I'd just like to share a few upcoming opportunities here at NYSARH. First, just a reminder, the call for abstracts for the 2026 Public Health Partnership Conference is due tomorrow, November 21st. So if you haven't hit that submit button, you still have a little bit of time. Topics for presentations range from workforce development, data, technology, and AI in public health. Practice, public health policy, and implementation. So we hope to see you there in Lake Placid on April 22nd through the 24th. And Holly will go ahead and drop that link in the chat for you if you haven't had a chance to see it. Next, I just wanted to talk a little bit about Giving Tuesday. Our development committee here at NYSARH is taking part in Giving Tuesday, which takes place leading up to December 2nd. All funds raised will support NYSARH programming, and Holly will go ahead and drop that link here as well. So if you are so inclined or able to give, we appreciate it because together we are stronger, healthier, and more connected. Another upcoming opportunity is on December 11th at 1 o'clock. NYSARH's project coordinator, Amanda Horner, and our rep fellow, Joshua Groh, will discuss the results of the statewide aggregate rural health needs assessment, or as we fondly refer to it here as SARNA, focusing on mental health and well-being. Holly will also drop that link to the chat for you as well. And just a reminder, today's session is available for CHESS credits. Let us know if you have any issue obtaining that. And I'm going to review our discussion today, our disclosure discussion, excuse me. And I'm pleased to introduce today's phenomenal speaker, Dr. Carrie Cochran-McLean, who serves as the Chief Policy at the National Rural Health Association. Carrie joined the staff in the National Rural Health Association in 2020, where she is the head lobbyist for the association and is responsible for driving the policy agenda for rural health for the 21,000 member organization. She has more than 20 years of experience working in federal health policy development, including serving in the senior executive service at the U.S. Department of Health and Human Services, Deputy Director at the Federal Office for Rural Health Policy, and as a principal at Health Management Associates. Carrie earned a B in sociology from Willamette University and an MPA with a concentration in health policy and management from the Maxwell School at Syracuse University. She completed a Doctor of Public Health at the UNC Gillings School with a focus on access to obstetrical care in rural areas. So Dr. Cochran-McLean, I'm going to pass it off to you. Thank you.
Thank you, Jennifer and Carrie. I'm Carrie. You guys can just call me Carrie. So I am delighted to be here with you on National Rural Health Day. It's such a treat to get to spend a little time together on this special day of the year. And my job is to talk a little bit about what's going on in Washington, D.C. And I could pretty much guarantee that I would be happy to switch you spots anytime. I'll come to New York, you guys come down here, because it's nothing but chaos down here these days. For those of you who don't know NRHA, we, the National Rural Health Association, we are a nonprofit, nonpartisan, membership-based organization, much like your lovely New York equivalent. And our role really is to provide leadership on rural health through advocacy, communications, education, and research. And since rural health is a big old portfolio, there's a lot under our umbrella. As we think about working with members of Congress and the administration and our state partners, we organize our advocacy efforts in 3 pillars. Really at the foundation of it all is trying to build rural health opportunity, and address some of the really challenging health outcomes, life expectancies that we have in our rural communities, and move the needle on the factors that impact those. We also work to develop a robust rural health workforce, kind of soup to nuts, training to placement to retention. How do we make sure we have the clinicians in place to take care of our rural populations? And last but definitely not least is helping all of our rural facilities keep their doors open and viable so that they can continue to provide access to care in their communities. So today I am going to talk about HR 1 or the One Big Beautiful Bill or the other, whatever name you have for this bill. Lots of people have call it different things depending how you feel about it. I'm going to call it HR 1 because it's the easiest thing to say, but the bill that passed on July 4th of this year. I'm also going to give some updates about what's happening in Congress, what's happening with the administration, and then how we can all work together to advance some of our rural health priorities. I am happy to take questions along the way. I have the chat set up here. I did. Let's see, it disappeared on me. There it is. Yes, Jennifer noted, please feel free to drop things in the chat. I also am happy, I'll leave some time at the end so we can have a little bit of a discussion if needed too. So HR 1, just a little bit of context setting for this. So you all know that Medicaid is really a lifeline for rural America. And because of the high rates of coverage for individuals in rural communities, it can play a larger role in terms of coverage and payers for our providers than when we compare it to some of our urban and suburban counterparts. So this is based on 2023 data. Looking at how Medicaid and CHIP coverage is in New York, with the darker the blue, the higher the rates of coverage. Nationally, we've got about just under half of the children living in rural areas having Medicaid or CHIP coverage, and about 1 in 5 adults in most of our rural towns having coverage through Medicaid. So definitely a
I'm
big,
sorry, can I just pause you for a
yeah.
second? We don't have your slides up.
Oh, I'm sorry, you guys.
No, that's okay.
I
You
went
great,
through
great
this whole
materials.
thing about how I can share my slides and I'm going through them and I forgot to do that part.
Thank
How
you.
about now? Can you see them now?
Perfect.
All right.
Thank you.
I was on a roll. Do you want to see that? I can go back to the other ones. Here's the agenda and here's our pretty picture of the Capitol. Okay. So, thank you, Jennifer. I thought you were going to ask me a really hard Medicaid question already. I was like, "Ooh, we're starting early." Okay, so Medicaid is a major source of coverage for individuals. It's a major payer in our rural communities. As we look at HR 1, we know that a significant portion of um, how HR 1 was paid for were cuts to the Medicaid program. We saw about $1 trillion or anticipate about $1 trillion being cut from the Medicaid program and health related programs. Um, and a lot of that is coming from a handful of states that have, in terms of rural impact, a lot of that is coming from a handful of states that have large rural populations and who have expanded Medicaid. And unfortunately, New York is up there on that list. This is analysis done by the Kaiser Family Foundation, and I think New York is like number 5 or number 6 in terms of the largest decline in Medicaid spending in rural areas anticipated based on the cuts to Medicaid. How that plays out in your kind of rural health infrastructure and rural hospitals. This analysis was done in partnership with the Chartis Center for Rural Health, where they looked at when, again, it's looking at the coverage for the individual, but then it's also looking at how is that going to impact the larger rural health infrastructure. Looking at hospital expenditures, how can we expect rural hospitals to be impacted by the cuts? Looks like in New York, about 3% of Medicaid, of rural hospital funding comes from Medicaid. So you can see how, based on the anticipated cuts, overall, there will be about a 15% loss to rural hospitals prior to the Rural Health Transformation Fund being applied. I know this can get a little wonky, but hopefully that makes sense. With those numbers, we know that nationwide, we're expecting about $137 billion taken out of federal Medicaid spending just to rural areas as a result of HR 1. Now, you'll recall during the debates in Congress, there was a lot of talk about rural hospitals. Thank you all for lifting up those issues, and we all did our job well, that rural health was a focus of concern here. So Congress created the Rural Health Transformation Program, and in the conversations during the Hill debates, the transformation program was really introduced as kind of an offset, as a way to help rural hospitals cope with the cuts that are anticipated. But when you look at the statute and when you look at how CMS has implemented the program, it's definitely not a direct one-to-one offset. So just because a rural hospital might be, or a provider, it might be losing money due to HR1, it's not guaranteed that they're going to get that made up by the transformation program. Just purely how the statute was written and how CMS and the administration is implementing the program. Really apples to oranges there. Even if they were doing a one-to-one, which they're not, we know that it's the transformation funding is only looking or anticipating to offset or bring in about 50 billion into rural areas, and again keeping that higher number of 137 as the anticipated loss. We're heading into a time period where we're going to see some additional strain put on the rural infrastructure and definitely individuals in terms of coverage. So a little bit just more context setting of why that's important. This data is from at the beginning of the year, prior to HR1, prior to any of the debates that have happened this year. Rural hospitals have been struggling. We've had over almost 200, just under 200 rural hospitals that have closed or stopped providing inpatient care since, well, in the last 15 years. And there's, again, at the beginning of this year, there were over 400 more that were vulnerable to closure. So this is additional strain on an already strained system, which, again, I know I'm preaching to the choir, but it's always part of the context setting I like to give to emphasize why we need some of the policy changes we're going to talk about. So what's in HR1? There's a lot in here. It gets super wonky. I'm not going to go into all the weeds of it, although I'm happy to answer some questions on it if helpful. But the way I look at the Medicaid portion of HR1 changes, I look at so I look at how it's impacting eligibility and enrollment, and then how it's impacting the way states run their Medicaid programs. So in terms of eligibility and enrollment, the piece that we heard the most about, rightfully so, is the new requirement around the 80 hours per month that individuals in Medicaid would need to be working, in school, volunteering, or looking for employment. The main concern there is that a lot of individuals covered by Medicaid are already working, and the fear that some of these requirements will create new administrative and paperwork hassles and burdens that will lose to loss of coverage. The other piece of that is the law is requiring people to get their eligibility determined or redetermined every 6 months rather than the 1 year that it is now. So a lot more process anticipated through this. Those changes are going to be effective the beginning of January 2027. The beginning of October 2028, there's also going to be an additional layer of cost sharing for adults who have their coverage as part of the expansion population. So in New York, this definitely applies to you all. Cost sharing is not something we use a lot in the Medicaid program because of the affordability issue. So that is another element here that we are keeping our eye on. And then related to eligibility and enrollment across both Medicare, Medicaid, and the marketplaces, there were changes to changes to how lawfully present individuals can be covered, and a restriction that around the definition of who's eligible, the individuals who are lawfully present, who is eligible still for coverage. So it basically is restricting qualified status to green card holders, certain Cuban and Haitian immigrants, and then citizens of the freely associated states or COFA immigrants. So it is restricting a number of folks who are lawfully present who previously could get coverage from coverage, again, both in Medicaid marketplaces and marketplace subsidies and Medicare. So another place where we're losing some of our eligibility and eligibility coverage. Related to the financing of Medicaid programs, so the second bucket of changes, there are two main areas that we saw addressed here. Both relate to how states are able to finance their Medicaid program and then distribute payments or focus payments to certain services and Medicaid. So provider taxes basically is limiting how much resource or revenue states can bring in through what they call the provider tax, which is on providers. It's also on health plans and others involved in healthcare as a source of revenue. And then the state-directed payments are payments that allow states to really focus in on certain populations or priorities that they want to improve or address. So, for example, a number of states will use state-directed payments to help support rural hospitals, create a rural hospital fund, recognizing that the current Medicaid reimbursement isn't sufficient for them. So we are concerned that as these go into place, there's going to be either kind of reductions in eligibility for individuals. There's going to be cutbacks on services that are covered under Medicaid programs at the state level, and then potentially reductions in reimbursement. And we really are seeing states already start the conversations on this. While these changes don't take place, a lot of them not until 27, 28, states are already planning and figuring out how they're going to make some of these deficits, how they're going to address some of the deficits that they'll be facing. So Medicaid was the area that was the most impacted. There were some changes in both the marketplace and Medicare I want to highlight. So the marketplaces, these are called a lot of different names: health insurance marketplaces, ACA marketplaces. Basically, this is the platform that individuals who don't have otherwise kind of credible coverage, employer-sponsored coverage, it's a platform they can go to buy insurance. It's also a platform that small businesses can use to buy insurance for employees. The way it is set up, recognizing that even this kind of pooled ability to get more affordable coverage, the premiums, the costs, your monthly payments can still be unaffordable for a lot of folks. And so they have premium tax credits and other subsidies to help support individuals in their payment, in their ability to buy coverage through the marketplace. So the HR1 package, the big change it made to marketplaces is basically removing auto renewal from a marketplace plan. So most of us who have employer-sponsored insurance, if you're a good steward of your insurance, you go in during open enrollment and compare what you used and spent last year and look at your options and decide if the one you're on is the right one. I will be the first to admit I rarely actually do that. I say, hey, I've been happy with my plan. Yes, okay, I'm just going to stick with it. I might not even think about it. Now, with the way the marketplaces are going to be set up, is that individuals will need to go back in and re-enroll and go through verification all over again every year in order to retain coverage and retain subsidies for that coverage. So that is the most significant change. Again, concerns that we'll lose people from coverage purely out of process and timing and awareness. This HR1 did not address the issue of the enhanced premium tax credits expiring, which was the big crux around the government shutdown. I'm going to talk about that in a little bit. But lots of conversation around marketplaces that we don't typically have in the rural health policy arena. There were a few things in the Medicare space. I'm not going to go into a lot of detail out of sake of time, but I do want to flag for people because this is a new development. The HR1, the bill in itself, was not, it wasn't a balanced bill at the end of the day, meaning that it adds to the federal deficit somewhere between $3 to $4 trillion. The estimates keep growing, honestly. So I think we're closer to the 4 trillion number now. And when a bill adds to the federal deficit like that, something called PAYGO kicks in. PAYGO then would basically take a cut out of everything moving forward in the federal budget to make up for that deficit. And that's a very simplified way to say it. But PAYGO is why we have the Medicare sequestration we currently have from 2011 legislative activity. There was a lot of concern because of the size of this bill that there was going to be another round of PAYGO cuts through Medicare sequestration.
All right, looks like we're having some technical difficulties. Oh, there she is. All more reason why we need stronger access to broadband. I'm just going to say it.
Okay, so let me make sure I'm sharing still. Let me go back to that. Can you see me?
We can see you, yes.
Okay, see the sharing? Okay. So basically, we were concerned that there would be an increase in the Medicare sequestration due to PAYGO. We had the 2% now. There was concerns it would go up to 6%. In the bill that reopened the federal government that I'll talk about in a minute, they did address this issue, so it has been waived and we will not see those additional cuts. So that is a silver lining of good news going into the next year. And then one more thing in HR1 to flag for you all is there were changes in the education policy space that are having impacts on the amount that individuals can borrow related to graduate student loans. And this is particularly impactful for our clinical community, those who want to go to med school, those who want to get an advanced degree or like an APRN. There are now caps on how much they can borrow, which will impact, we believe, who is eligible or who not eligible, but who can actually afford to go to school and take on and still have resources with these caps on loans. So concerns there, and we've been working with other associations more in the health professions space to figure out how we might be able to reverse some of this. So that's as weedy as I am going to get. I know a lot of that is weedy, but any questions with that before we go on to the next section about what's happening in Congress? I don't think I see anything in the chat. Jennifer, do you?
Just a request if you are comfortable sharing slides afterwards.
Oh, absolutely.
Great. Yeah. Thank you.
All right, well then I'll keep going. Related to the shutdown. So, oh man, I like how we call it the we're using the term shutdown showdown because it feels a little bit like I'm from Montana, so it feels a little bit like a rodeo or something, but we made it through. This was the longest government shutdown in history, as you all know, 43 days. And like I said, primarily the crux of the issue was around the extension of the enhanced premium tax credits in the marketplace. So basically, like I said, those premium tax credits help individuals pay their monthly costs for insurance. During COVID, there was a increase in those both to individuals and to individuals and individuals. There was an increase in individuals, the amount of federal poverty level. So individuals over 400% of the federal poverty level could get access to some of that support, as well as an enhancement in how much people were getting. That has been that expires at the end of this calendar year. And so the debate now in Congress is, should we continue to extend these? If we don't extend these, or what changes should we make, or should we just stop it altogether? So I'm going to talk about that more in a minute and how it relates to rural communities. But that was, again, kind of the hang up here for the FY26 federal budget. Um, Congress was able to reopen the federal government and put us on a short-term budget through January of 2026, at which point they will need to come back and negotiate what the full year's budget is going to look like. In addition to that short-term expansion of discretionary funding for the government, there are a number of provisions, primarily under Medicare, that were expiring as well. I think the most known is the telehealth flexibilities that were created during the pandemic, but we also have a number of rural designations like the Medicare dependent hospital designation and some ground ambulance bonus payments for rural areas that had expired and now are extended through January 30th, at which point Congress will need to make some longer term decisions about those programs. Hopefully to extend them again. It'd be great to make them permanent, but all of that comes with a cost, and oftentimes Congress isn't willing to bite the bullet on the cost associated with those kinds of designations. So they just do these short term, 3 to 5 years, sometimes even shorter plans to continue to allow that behavior or payment methodology. I promised I wasn't going to be weedy, but I'm going to be weedy again for a minute. So the discretionary budget, the annual federal budget, is made up actually of 12 different bills, healthcare being one of them. Another one we focus a lot on is the agricultural and USDA space, because there are quite a few programs there that either indirectly or directly support rural providers and support things like telehealth. So Congress actually was able to come to a compromise on the ag bill. So this has passed for FY26, and we know that there were some great investments both for loans to support rural healthcare facilities, as well as telehealth and technical assistance for rural hospitals. So another piece of good news that we have going into next year. And then in terms of the health related package, you'll recall that the president, when he kind of kicked off the whole budget process for the year, his budget eliminated a lot of money out of HHS, including some of our core rural programs like our state offices of rural health, our flex program, our area health education center program, grant program. So we, thanks to all of you as our rural health advocates, we were successful in both the House and Senate kind of proposals, which have not been finalized yet, but their proposals have our programs at level funding or even enhanced funding compared to last year's levels. So we really want the government, we really want Congress to move forward with a new FY26 appropriations bill using these numbers, because it will mean higher amounts in some of our core programs for grantees and grants out to rural areas. So that's an important message, an important takeaway that we want folks to hear today. Going back to the marketplace enhanced premium tax credit. So you'll recall the government was shut down. The Dems were saying we need a vote on this, and we aren't going to reopen the government until we get a vote. They ended up compromising to say, well, let's put a vote on the calendar. We don't actually have to have passage of it in order to reopen the government. So sometime in December, Congress will be readdressing this issue. Again, the enhanced premium tax credit, so the bump up does expire at the end of the calendar year. And we know that it helps about 1 million rural individuals, these enhanced premium tax credits do, a combination of both adults and children. And without them, and in some cases, their health insurance, their monthly premiums will be increasing significantly. So we at NRHA believe that this is in some ways a even more impactful issue in rural communities where we know that both due to our income levels in rural areas and some of the allowable factors around geography and age, our coverage and our ability to pay for coverage is in some ways worse than our urban counterparts. And so we see a greater savings due to these enhanced premium tax credits, and therefore it's really important that Congress acts to extend them as much as possible. There are a couple of different pieces of legislation that are moving forward on this front. You're hearing now Republicans come out with a number of different proposals on how they would like to see the enhanced premium tax credits, how that program could be adjusted. I think there is a willingness to have that conversation. The challenge is that open enrollment has already started for 2026 and we're less than 45 days out. So making big structural changes to the program at this point for 2026 is very hard. I don't know if they're going to get their act together to move forward with it or not, but they're going to have to move quickly. If they don't, then there will be, as you will have heard in popular press, pretty significant increases in premiums for a lot of individuals who may choose to forego coverage because they just simply can't afford it. So I anticipate between the budget and the EPTC conversation, that is going to take up most of the energy or floor time in Congress before the end of the calendar year. But we do have a whole nother year in this 2-year 119th Congress to address issues. And we still hear a lot about other proposals proactively that members of Congress want to work on, things like drug shortages, pharmacy benefit manager, I should say, reforms, and 340B program reforms. We're hearing more about artificial intelligence and trying to put some parameters on that. So while those are all important, we also believe that there are some high priority rural bills that we are trying to get Congress to pay attention to and pass. So just a little bit on some of those. Within the rural hospital space, our what I call marker bill or our ideal bill, if someone walked up to me and said, "What could I do today to stem the bleeding for rural hospitals?" I would say, pass Save America's Rural Hospital Act. It does a whole range of things. There are, I think, 12 to 14 different policy proposals in this, but basically kind of helps address some of our conditions of participation challenges in Medicare. It deals with elimination of sequestration and more support for bad debt. Would reauthorize the Flex program. There's a bunch of stuff in here. So that's kind of our core bill we're trying to shop around, but recognizing that a package with that kind of cost might be hard to pass all at once. We have some other bills that will bring in portions of that as individual provisions, like reopening necessary provider status for critical access hospitals with certain guardrails is an example of one of those. We also have a number of bills in the rural health clinic space where we're looking to modernize the statute associated with that designation. Things like removing limits on behavioral health versus primary care in our facilities, modernizing some of the PA and P requirements to be in alignment with state laws. And then in the area of telehealth, definitely a high priority to get those flexibilities extended, but also to make sure that we are supporting financially the services that are being done by RHCs in a telehealth capacity through payment parity, ideally with in-person payment parity. We are hearing a lot continued from our members on Medicare Advantage. It's the year to talk about payment and coverage. And so within the MA space, there are a number of bills that we are lifting up that really address issues around prior authorization and prompt payment, clean payment of claims or payment of clean claims. because we hear that being the biggest pain point right now for members. But we also are developing legislation around creating floor payments for our rural providers paid under an alternate payment methodology like critical access hospital, having a floor payment equivalent to traditional Medicare should that entity enter into a contract with Medicare Advantage. We're exploring network adequacy and how to address some of the steerage or denial of services we're seeing in some of our communities so that people can stay locally for care. So lots going on in the Medicare Advantage space. And then in addition to all of that, for many of us, we know how important the programs out of the Federal Office of Rural Health Policy are. And when we have those grant programs, you need both the appropriation that funds the program, but you also need the authorization that gives permission to the administration to implement the program. So we are really focused on making sure that we have all of our core programs either reauthorized because they're coming up for they've either coming up for expiration or they have expired, or we have really successful ones like the Rural Residency Planning and Development Program that started as a pilot and never has had an authorization in law, and wanting to make sure we get that in there to protect those core kind of what I think of as like rural infrastructure programs out of the federal office. So having some great success in that area, excited and hopefully we'll have those ready to go so that next year in the second term of this Congress, we're able to get some of those passed. Okay, I'm gonna do a quick pause. Any questions on any of the legislative stuff? Okay. So in the administration space, working with the Trump administration, the big thing everyone's talking about these days is the Rural Health Transformation Program. You all, I'm sure, are very aware of that program, but just as a reminder on some of it, it was the $50 billion I talked about earlier that is going to help and support rural communities. As I mentioned, we get a lot of questions from media and others about how this is going to offset the Medicaid losses. And in my mind, they're really two totally separate pools of funding. This funding really helps to bring rural communities up from decades of underinvestment to a level playing field where we can really move towards and be ready to do transformation rather than a lot of times when we ask rural providers now about moving towards value-based payment or other models that might help to support the sustainability, they say to us, well, I'm just trying to make payroll. Like I don't have the bandwidth or resources to move into this space. So in my mind, this transformation program is really helping to level that playing field and bring rural providers make them ready to be able to do some of this innovation that is so needed in our communities. So there's two tranches of funding within that 50 billion. The baseline funding, which goes to every state that applies, and every state did apply for this funding. So every state will equally be awarded that baseline funding. And then there's workload or discretionary funding that is based on the rural factors outlined by Congress and CMS in the state, how states score on those rural factors, as well as how they did on their applications in developing their rural health transformation plans and in some of the state policies to support those plans. Those plans are all developed based on initiatives that fall under the 5 program strategic goals around MAHA, and so addressing population health prevention, chronic disease, fostering sustainable access. So how do we help make our rural hospitals and other providers more viable in the long term? That is a space where we could do some level of provider payment, but only up to a certain amount, and I'll talk about that. Workforce development, kind of, again, strengthening our capacity to do recruitment and retention in rural areas, maybe addressing some scope of practice barriers that have existed. Moving into more innovative care models, hopefully value-based payment, but other models like clinically integrated networks that may help support our independent facilities in our state, and then thinking about how we bring technology into it. Everything from updating your EHR and interoperability all the way to integration of AI and remote patient monitoring and the like. So like I said, that 25 billion of discretionary funding is based on kind of these three different buckets: data, your initiatives, and then what the state is proposing to do to support some of those initiatives under your rural health transformation program. Looking at the data-driven part of this, there are clear indicators that either were inferred in the statute or are, I should just say, identified by CMS that they are going to take into consideration in weighing a certain percentage of that discretionary funding for your state. And those are related to rurality, to the health of your rural facilities in your state, et cetera. UNC ran some data based on what they could figure out from CMS's numbers and showed like which states were more likely to get higher levels of funding versus less. And good news for New York is you guys have a higher kind of weighted value on that scale above 1 than some of your other kind of neighboring and states in other parts of the country. There are some restrictions on the transformation program funding. I'm sure you've heard of these, but while you can do construction, new construction isn't allowed, and you can only do it up to 20% of the state proposal. Same with provider payments. There's a cap on those, and then there's a cap on the amount that can be invested in an EHR program, which I think in some cases is a little bit tough for states that may have specific areas that they really wanted to push. But we'll find out because applications were all in and due November 5th. And at this point, we are all waiting with bated breath on what CMS's decisions will look like, which are statutorily required by the end of the calendar year, with funds starting in January. And I want to leave time for discussion. I do see Karen Madden. I know there are many folks who worked on this application for you all in the States who can probably answer questions better than I and probably have some great commentary. But before I open it up to Karen, I just want to do a couple of slides on advocating with NRHA. Our job is to make advocacy as easy as possible for you. So we have a number of resources that are that lay out issues, provide data, have policy proposals on solutions related to those issues. We also have campaigns where you can go on our website and find talking points and find pre-populated messages that can be emailed directly to your members of Congress that you can either personalize or just take the set message on what we think are some of the most pressing issues right now in rural healthcare. We have a tracker that shows you all of the bills that we're working on within various areas. So if you're interested in EMS or maternal health or public health, you can find out what legislation is in Congress on those issues related to rural. And then we have lots of ways that we try to communicate with you on a regular basis, including our weekly newsletter, our monthly grassroots calls, and just good old email and picking up the phone to call us, as well as coming to our Policy Institute in February. This is our fly-in where we support you all in Hill visits and work with you to get those messages directly to members of Congress. We also have members of Congress and the administration come talk to us. The invite is already out to Dr. Oz, so hopefully he will accept it. It's a really good way, if you haven't done a lot of advocacy, to get your feet wet in a pretty safe group. New York always has some good folks who come to the meeting, and we have a good time. So with that, I am going to pause for questions, see if anybody has anything that they'd like to add to anything I presented today, knowing that you have a lot of really great rural health experts on the line and in the state. And just thanks for having me.
Carrie, wow, that was a lot of great information, and you covered so many
it's like
so many topics. No, we appreciate it, and please get in the weeds with us any day. I think a lot of us are very wonky, so we certainly appreciate that. And I think the resources too at the end are just a phenomenal opportunity and resource that we have through you. So thank you for that as well. I'll go ahead and see if anybody has a question. You want to raise your hand, and we can go ahead and unmute you, or throw something in the chat.
I'll take reflections and venting too.
All those things.
All of the best. Yeah, Allie.
Ellie.
Hi. So thank you for this update. I think it's really great. And I think it's really showing that rural's kind of having a moment right now. We have a lot of attention focused on rural issues. And so I guess I'm wondering, how do we make the most of this from an advocacy perspective? How do we sustain this focus? Obviously, you've given very specific, very timely recommendations. But in terms of the bigger picture, how do we make sure that we can keep going?
That's an excellent question, and honestly, something we talk about a lot, right? I have just an example of that is, the $50 billion that we're getting through the Rural Health Transformation Fund. Again, amazing, once in a lifetime investment. I have some concerns that folks in Congress will be like, okay, we've checked that box, and we can move on. So it's really important that as new issues come up, our team is doing everything we can to understand the rural lens of that, the rural implication of that, and then feed it back out to the larger community to help convey that to their elected leadership. Because I think that that is what it's going to take to keep rural in the forefront, and understanding that again, the apples to oranges that the transformation fund is to everyday regular reimbursement. And I will warn you that the hits will keep coming. From what I understand, I mean, yesterday I was in a closed door member meeting on the House side, where I met with a number of congressmen and women to talk about site neutrality, because they really are thinking about taking that up in the hospital space. And I was like, are you trying to close rural America? Because if you put that in place on top of everything else, so it's that constant kind of drumbeat of awareness, and not to get. I think with the fact that there's still so much concern over HR1 implementation, I do think it is a time that we have a window to lift up other solutions. And we are getting receptivity to that. I don't know that they would admit it publicly, but we meet with Republican members of Congress all the time who voted for HR1, but they'll say to us, like, we know rural is hurting, so we'd like to do other things in that space. I think, just really candidly, the challenge is that Congress isn't doing much, period. So while we can get some momentum around maybe a rural package or inclusion of rural elements in a healthcare package, should one come up later in the year or next year, Congress still has to be able to come together to pass legislation. And part of that, again, is holding our elected officials accountable, raising up issues in the press and the media, and that kind of really kind of collective voice is so important.
Carrie, I'm curious. Sorry, Ellie. I'm just curious with like the tone of the Hill. Is there an intent to do standalone legislation or packages, or is it a complete focus on the government shutdown, and then what are our next steps from here?
I think now there is. Leading up to this point, I mean, the reconciliation package, HR1, took up all the oxygen in the room for the first half of the year. It was just kind of a crazy year. And then we went into government shutdown where we were working with staff on proactive bills, but they weren't in a place where they could introduce anything because the government was shut down. So this week in Congress is a really busy week. And so I think that to the extent that we have legislative time between now and the end of the calendar year, and really into January, I think that there is opportunity to get some done, maybe some things included in like a January bill that would fund the government. But I'm hopeful that we're finally getting teed up to do things in the latter half of this congressional cycle. And we're going to be going into an election year, so sometimes those are quieter years just because of the election cycle and people not willing to kind of take votes. But at the same time, it also can be a time when people want to take action and be able to talk about that action. So I think there's still some opportunity. I have to think there is.
Hope so. We tend to see that a bit in New York, that there's not a lot of focus on legislative activity, and it's like, oh, we can't do anything until the budget is passed, and we have to be able to do two things at once, I think.
Absolutely. Yeah.
Yeah.
And that's really frustrating when you can't get the budget passed, because it's like, that is literally baseline of what you're supposed to do
Yeah.
is allocate funding. If you don't do anything else, you're supposed to be doing that. But it's an interesting time. And then,
Yeah.
you've got all of this administration is more active, let's put it that way, than a lot have been on activity that's been a little bit more disruptive. So that also throws kind of a wrench in productivity because people are distracted by lots of different things.
I don't see another hands, I'll turn it back to you.
Thanks. This is not really a legislative question, but kind of just a bigger picture, going back to this idea that rural is in the spotlight. There was a poll just this week or last week from the American Communities Project that said that rural communities are feeling more optimistic about the future. And so I wonder, how can we use this to rebuild rural community trust in healthcare and rural community trust in our institutions, and not risk losing them again when they start to feel the pain?
Yeah. Well, I think that the investments in the Rural Health Transformation Fund will be one way for people to really see some tangible improvement in health and well-being in their rural communities. I have said a couple of times that if nothing else, like if tomorrow something happened to that $50 billion, not that anything ever would, but we at this point have 50 state rural health transformation plans. Like we have, every state in the country has sat down and really thought about what's needed in rural healthcare. They've gotten that feedback from individuals living in rural health in rural areas, and they have a plan for moving forward. And that in itself is pretty powerful. So I think, there are a lot of things we don't have control over. We don't know how CMS will fund the plans. We don't know, how states will implement the plans. But we at NRHA are trying to collect get a copy of everybody's application and really understand, like, where are there some best practices? Where are there policy approaches that we can share or lift up or figure out how to move forward, even if the transformation funding doesn't end up supporting that one piece of it. So I think that there is that energy around the transformation funding that we're really hoping will be kind of a place, like I said, to level some of that playing field so we can put larger, longer term innovations in place that hopefully will have kind of that sustaining effect in our communities. I'm seeing a note in the chat here. Hold on, let me see. a really good question about are we working in partnership with others on these issues? And most definitely. So on the enhanced premium, well, both on the Medicaid stuff and on the Medicaid changes and on the advanced premium tax credits, NRHA has been really active in a number of coalitions that are not just with other rural organizations, but with kind of folks across healthcare. I do think that the rural story is particularly impactful right now, both in terms of because red states that tend to be more rural states are in leadership. And so being able to make that connection to leadership and what it means to their communities is an important lever. And then just to Ali and other people's points, just the awareness of rural hospitals and rural health right now is higher than normal. So we have, I will say, not only proactively, but been asked by a lot of folks to kind of come in and tell the rural lens of whatever the issue is and help to lift it up. And I'd encourage folks, I mean, that is a really important part of successful advocacy is that coalition building and having a number of people kind of tell the story of why whatever the piece of legislation is that's important. I am always looking for, and I would welcome other ideas of partners that we could do that with. So if Marcia or anybody else has ideas, I'm happy to have that conversation, discussion, and would love introductions as much as possible.
Hi, does anybody else have any other comments, questions, accolades for Carrie?
Well, it's been lovely to be here with you all today. I really appreciate the opportunity. And like I said, to get to spend a little of National Rural Health Day with you all, it's very special. It's good to see Karen still standing at the end of the last 2 months or so. I see you raise your hand, Karen. Did you?
I did, just real quick. Hi, Carrie. It's nice to see you. I just want to say thank you for taking this time with NYSARH today, and just wanted to thank you for being such a great partner over all these years. I've known Carrie in her pre-NRHA life, when she was working in another capacity in rural health. So it's just she's been great for all these years. So I'm happy to see you here today, Carrie.
Well, right back at you, Karen. It's pretty. We have a really great. I feel like that's one of the things. I mean, I'm from Montana, so I'm from a rural area, but man, the people who work in rural health, there's just so much passion and dedication and good people. So it makes our day-to-day work quite fun, I think. It helps us keep up with all of that, or put up, I should say, with all of the members of Congress we have to deal with. Can I say that?
And yeah, and Carrie's right about that. The rural health world it's a small world, and it's really nice having the NRHA there and knowing that I can pick up the phone and talk to Carrie or Brock or Alan at any time, and I won't get bounced around to a lot of different people who say they can't help me, and they're always just great. So there's great partnerships all over rural health. That's I think one of our big strengths.
Absolutely. So on that note, feel free to reach out. I just dropped my email in the chat. But yeah, we're here to help, and we've got a whole team, and we really appreciate the partnership with all the organizations in New York, and we'll get it done collectively.
Okay.
Great. And Carrie, thank you so much. We'll share this recording and the slide deck with our members. It's such an available resource, so we really appreciate you offering to share that with us.
Anytime.
All right, I'm just going to close this out quick. We do have an evaluation form that if Holly could just pop in the chat. This helps us identify what content you as our members want to hear. And of course, how do we inform future events? And then just real quick, because I know we're just at time here, we hope to see you all on December 11th for our Sarno webinar. And everyone have a great rest of your day and happy Rural Health Day.